Hey guys, it's Gianna, Midwifay. Today I wanted to talk about the BRAINed, I call it, acronym for shared decision making between you as the patient and your provider. It's also known as the BRAIN acronym or the BRAN acronym. I call it the BRAINed acronym, and I will tell you why. Let's take a look. Okay, so this BRAINed acronym is a template that we can use in order to have shared decision making with our providers. That means to take a step back and take a listen to what the provider is recommending or suggesting and making sure that it is in alignment with our beliefs, our desires, and what we want for our pregnancy or our birth. I will firstly say, this is only appropriate to be used in non-emergent situations. If something is an emergency for yourself or your baby, or there's a medical emergency, if you're using this outside of pregnancy, if you're bleeding out and your leg's broken, now is not the right time to necessarily step back and say, I need to use my BRAIN acronym. So this is for non-emergent situations where a plan of care is being discussed and recommended, and you and your partner are deciding if this is right for you with your provider. So the first letter B talks about benefits, okay? This is probably the one that we providers share the most when we're recommending something, because we're trying to get you to go with this recommendation. So generally this means, what are the benefits to you or baby medically for doing this intervention? Depending on what these interventions or the recommendations are, these benefits can range from higher likelihood of achieving a spontaneous vaginal delivery or decreased chance of needing NICU or neonatal support at birth. So it really depends on what in pregnancy you're talking about. What I want to point out for benefits, something that I don't think we always think of, is there is a benefit to kind of staying on the same page with your provider and your healthcare team. I don't want this to be the first benefit. Again, it needs to first be medically, first and foremost. Is this what's best for you and your baby? However, I don't want patients to forget the benefit of staying on the same page with their team. So if you refuse or you're declining kind of every recommendation that your team has, unfortunately, but it is true that might color the providers or the healthcare team's view of you. So if you are declining, a small intervention because the benefits aren't significant to you medically, please consider that the benefit of your team kind of being positive and support of you is another benefit to think about. Again, it's not the first one, but it is something that I think you should think about when considering benefits. Risks. Risks is the second part. Again, I think a lot of practitioners think that we're well versed in explaining this part. So what are the risks to me and my baby? Why are we doing this? What are the risks if we don't do this? Again, I think as practitioners, we think we do this well. However, I think there's a difference between relative risk and absolute risk, and that's what we have to look at when we're counseling patients on their risk of something happening if we don't do a certain intervention or recommendation. So far we've talked about what are the benefits, what are the risks. This is kind of really the heart of it. What medically, why are you recommending that this happen? And then the next thing we talk about are alternatives. So what is an alternative to this intervention that you're recommending? This one might be harder for providers to answer because they haven't necessarily walked through many alternatives, or the only alternative they might say is a really bad and scary outcome for you and baby, which is highly unlikely. So I encourage you, when you're asking for an alternative, that you don't stop until you get an answer that is adequate, okay? So a different alternative, maybe a different treatment regimen you can be on, a different kind of expectation you can have. So what are alternatives to the intervention or recommendation that's being displayed to you? And now we'll talk about the I. The I is sometimes left out in the acronym. I like to include it. The I stands for intuition. What does your gut say? What do you feel is right? As the person growing this baby, birthing this baby, what do you feel is right? Again, this is not for emergency situations, as I pointed out in the beginning. I think there is something to be said for all people about our intuition and our gut feeling when we meet a person, when we're talking about something. How does it feel to you? Does it sit right with you? Does it make sense to you? We've gone through the BRA. Did all of those things make sense to you? So checking in with your gut and your intuition about this recommendation, I think that is something that should not be overlooked. The N stands for what if we do nothing? This could probably be included in the alternatives, but for sake of the acronym, it has its own letter. What if we do nothing? What would that look like? Again, I would encourage you to demand an answer from your practitioner that's not just, well, if you don't do anything, you and your baby, you're going to be at high risk for death or for a severe complication. Again, that's highly unlikely. So just kind of asking that question, again, maybe in the alternative section of what doing nothing, what that would look like, what kind of risks that would pose, what kind of benefits that might pose to you and your baby. Along with risks to yourself and your fetus, if you don't do the procedure, I would encourage you to ask, what other potential studies or tests will be done after this one? I think the cascade of interventions, one study begets another test, that is truly a potential risk of a lot of interventions and things that we do in medical practice. So I think it's reasonable for you to ask that in the risks section, are what other potential tests, studies, procedures will be recommended to me after I say yes to this recommendation. This do nothing portion is really expectant management. So what would you reasonably expect to happen if we just left my body and my baby alone? Not what is the worst of the worst of the worst that could happen. What would you reasonably expect to happen if we did nothing? I think that's one way that you could word it with your practitioner. And the D is for discuss and decide. I recommend that you do this privately with your partner, your support person, your doula, not with the provider in the room. If this is in labor, you're able to ask the nurse and the provider to step out. If it's in a clinic appointment, you can ask them to step out. It's important that you have the time to really talk about it without the pressure of the provider there. Again, this should be a non-urgent, non-emergent thing. So you should have at least 5 minutes to be able to talk about this, if not longer. So you take the time to discuss, decide, and then you have an assigned time when you'll meet back up. So if this was at a clinic visit, maybe you'll say by the next visit you'll answer, or after the weekend you'll call the office with a decision. If this is in labor, you might look at the clock and say, okay, we're going to talk about it, my doula and my partner and I. Well, you please come back in the room in 10 minutes or whatever it is. So I encourage you to take a step back, to have the time to yourselves to talk about it, but come up with a decided upon time when you're going to come back together to share that decision and discuss. This BRAINed acronym is something that I think you can find really helpful when facing differences in plans of care or recommendations, or especially if there's changes that have happened kind of all of a sudden that aren't emergent. This can be really beneficial to help you engage in shared decision making. If you're a provider watching this, I encourage you to lead this discussion and put it in this framework for your patients if they don't know or they're not asking these questions. I think shared decision making is something we all strive to do and think we're doing. However, we don't always step back and really take that time to do that, to give true informed consent. As a patient, as parents expecting your baby, I really encourage you to practice this because it won't necessarily come naturally to you. So if you anticipate some kind of change in your care, or you've encountered something like this, practice with your partner, practice with a trusted friend, practice with a doula, practice asking these questions to someone that's not your doctor, not your nurse practitioner or midwife, because there is, like a power shift that does often cause you to feel intimidated when having conversations. So really don't feel bad about practicing this with someone before talking with your provider about this.
In order to practice this brained acronym, I wanted to go over a case study that I think is a pretty common scenario that I see in the hospital. So this is a case of a lady having her first baby and her water is broken and she's not quite very dilated on active labor yet. So she gets to the hospital and her OB recommends that she be admitted and that we start Pitocin to move her labor along. So let's go through the brained acronym in this case. When Amanda asks about the benefits of starting Pitocin, very likely the provider has lots of answers here because this is what he wants her to do. So he might say something like, starting Pitocin shortens your labor course, very likely because Pitocin causes stronger and more regular contractions. He'll probably say, again, how shortening the labor course is going to decrease her chance of infection since her water is broken. Something he won't say is that point that I mentioned earlier that, again, one of the benefits of kind of going along with a recommendation is staying on the same page as your healthcare team. So again, although that is not the first line, the first thing I want you to think of when you're thinking about benefits, it is a potential benefit of going along with the recommendation. Here is where things get a little different. Likely when Amanda asks about risks, the provider is going to default to the risks of not starting Pitocin because, again, starting it is what he wants her to do. So he'll likely talk about infection. When your water is broken, there is an increased chance of infection. However, that's not necessarily right away. So the provider is likely going to talk to her about increased labor time being a risk factor to developing intrauterine infection during pregnancy. Very unlikely that the provider will talk about the risks of starting Pitocin. That's something that Amanda and her partner can ask about. But here I listed some risks of starting Pitocin. And again, like I talked about in the video, when we're asking about risks, it also, we also want to know about further interventions, further testing that could happen based on going with this recommendation. Now we get to the alternatives portion. This might not be something that your provider has a lot of answers for. Usually things are done one way in the hospital, maybe one or two ways. So honestly, a lot of times providers don't have a lot of alternatives. This may be something you have to have done your research on before coming to the hospital. Here are some alternatives that I've used with patients in the past in this scenario, some alternatives that you can ask about if you are in this scenario. So again, make sure we ask about alternatives when we're being recommended a course of action. Let's talk a little bit about the I part here, her intuition. Everyone has a different level of comfort with the pain they're experiencing, with their transition into parenthood. So I really recommend that the patient step back at this point, that Amanda listen to herself and thinks, are these cramps, do I feel like they're getting more intense? Do they hurt? Does she really feel like labor is starting? Is she comfortable? Does she feel really prepared? Does she think she's coping well? Is her partner a good support person? And or does she have another support person that's available to help if she went home? So really just checking in with herself to see how she feels right now in this moment to help her make the best decision. Now we're at the N. What if we do nothing? This is the part where you might receive some pushback from your healthcare team as well. It's not a question we get asked a lot, honestly. And at this time is when I really challenge, for you to ask something like, what if we watch and wait? Like, what is reasonable to expect if we do nothing? And this is where we pull out real data. Again, most of the time, unfortunately, providers and healthcare teams rely on the risks and try and do the scary thing. You're going to get an infection. This is what's going to happen. If you do nothing, you'll get an infection. When in fact, these are the actual numbers and percentages with how often people go into labor in this scenario on their own and risks of infection. So again, kind of demanding that you get a decent response that incorporates more of the relative risk versus absolute risk, and realistically what is reasonable to expect if you did nothing in this situation. And now we're at the D, decide. In this situation, our patient's in a triage room. She can ask the nurse or the provider to step out of the room for a second so she and her partner, she and her doula, she and whoever is there with her can think about it for a few minutes. I always recommend, again, you have to have a time to come back together. So look at the clock and say 10 minutes from now that they'll come back in and you will have a decision for them.
I hope you found this video helpful. If you have used this brain or brand technique before, let me know how you liked it, if you think that it was beneficial to you. Please share below your comments, share this with someone else. As always, I appreciate you watching. I'll see you next time. Bye-bye.